let's talk about the respiratory system. So, this is a great read. A lot of diseases, some of which you might be familiar with because respiratory infections are pretty darn common. And hey, we lived through a pandemic, right? So, COVID is going to come into this a little bit later in this lecture. But I do highly recommend reading this chapter if you've been skimming along. This is a good one. I'm going to start with the anatomy here. And the first thing I want to say is that the surfaces of your respiratory system have a lot of bacteria and viruses, right? It's normal. This is where the inside of your respiratory system is going to come into contact with the atmosphere. So we know that a lot of these are transient. They kind of stay for a week, they leave, maybe a month, leave, maybe they stay for longer, maybe they never stay. But that's normal. These are going to be diverse ecosystems that, have just found a perfect warm little spot to hang out. So there are some anatomical defenses that I want to mention. The first is just the shape of our respiratory system, like how air comes into the human body, is that it comes in through the nose or the mouth and hits a very steep 90-degree turn, which means all the air hits the back of the throat. Now, ideally, the air has kind of swirled around the nasal cavities or inside the oral cavity, come into contact with the wet, warm, sort of mucus and covered surfaces that kind of warms up the air. The mucus might trap things like dust, pollen, microbes, viruses, what have you. But that 90-degree turn is actually really important. That is exactly where our tonsils are located. There are pairs of tonsils that are really just masses of lymphatic tissue. Lymphatic tissue is just white blood cells all in one kind of localized area with a membrane around it. They're there to basically neutralize any potentially dangerous pathogen that has hit the back of your throat. This is also, coincidentally, why you tend to start feeling sick with a respiratory infection when you come down with a sore throat. Like, that's always usually the first sign, like, oh, I think I'm getting sick, right? That's where you want those microbes to stop and be neutralized. If they get lower, they can start to interfere with the larynx, which is your voice box. When that is inflamed, you lose your voice. When it gets even further down into the bronchi, that would be bronchitis, and that can kind of feel like a pain in your chest, like a heaviness in your chest. If it gets into the lungs, that can be actually extremely serious. You don't have a very good way of getting your immune system into the lungs. When you have inflammation of your lungs, your blood will vasodilate and start to, send fluid into that area, just like it normally does when there's inflammation. But fluid in the lungs, it fills up with water and you can't breathe and you can actually suffocate, which is actually how you die of a pneumonia infection. You're actually drowned in your own lung secretions, which is terrible. The other area that's kind of, almost sort of an aside here is that there is a direct passageway through the auditory or the eustachian tube from the back of the throat into the middle ear cavity. So that middle ear cavity is where you have your ear bones. It is a hollow, air-filled space. It's important that it is filled with air so that the tympanic membrane and the cochlea can all be at normal pressure. But when that area gets full of bacteria and pus and just kind of clogged up, it can make hearing difficult. It can hurt. It can actually bulge the tympanic membrane and cause a rupture of the tympanic membrane. It's no fun. Children are particularly susceptible to middle ear infections because their skulls are a little bit different shape. This auditory tube here is a little bit more horizontal, which makes it easier for the bacteria to crawl up there. The good thing is that as you're an adult, you tend to outgrow your tendency to have middle ear infections. But that's kind of the anatomical organization that I wanted to mention. You will also see this categorization in medicine of upper versus lower respiratory systems. And, it's all your respiratory system, But the demarcation or the boundary between the upper and the lower respiratory system is actually the larynx. So you can actually feel this if you kind of cup your throat and you swallow. You will feel the cartilages of the larynx kind of move up and down as you swallow. That's the boundary. Anything that is above the larynx is considered upper respiratory system or a upper respiratory infection. Anything below the larynx would be a lower respiratory infection. And again, lower respiratory infections are much more serious because the defenses that you have there, the ability to neutralize the microbes are just different, and they're sometimes inadequate to do the job. It's much better to have a sore throat and keep it right there. I will also mention that, back in the day, we used to take people's tonsils and even the adenoids, which are just another set of tonsils. They're just in a different location. We used to take those out pretty frequently when kids would get chronic sore throats, like strep throat. And we try not to do that now. We will absolutely remove them if there's an airway obstruction or there's some really good medical reason to do that. But when we remove that immune system structure, the tendency to get more lower respiratory infections because it just slips right back down the throat without stopping at the tonsils is higher. And again, much more dangerous to have bronchitis or worst case scenario, pneumonia. Here's what the respiratory epithelium looks like. And this is pseudostratified. It's kind of looks like multiple layers, but it's actually just one layer of cells. And there's quite a long cilia on the top surface of those epithelial cells. The cilia are very important because the mucus that falls on it, it's going to kind of move the mucus down. Now, the mucus might come into the throat or nose where you blow your nose or you spit something up, or you could swallow it. Either way, it's a good strategy to basically remove that kind of dirty mucus from that system. And that's actually probably your best defense, is just move it, neutralize it with either swallowing it or get it out of your system in general. But pseudostratified ciliated epithelium, respiratory epithelium, is pretty unique in the human body. It's a pretty good barrier, but certainly not perfect. All right, our first etiology that I want to talk about is strep throat. A lot of people have had strep throat. I had strep throat one time, and I was in college. I think I was a freshman in college, and it was over the Easter break, and I called my mommy, and I'm like, I think I'm going to die. I think I need to go to the hospital. And she's like, no, you're fine. It's just strep throat. And I was like, oh, okay. I didn't know it was that bad because I'd never had it before. I knew lots of people who'd get strep throat as kids, and I was like, wow, you guys are always sick. I'm fine, blah, blah, blah. And then I got it, and I'm like, oh my gosh, I was such a jerk. Because it was literally like razor blades in the back of my throat. This is streptococcal pyogenes again, the same thing that was the strep cause of many different skin diseases. This is resistant to phagocytosis, which means it can evade your immune system. That's kind of how you would normally neutralize bacteria in your throat, is just phagocytize it and eat things and digest them. It has quite a few cytotoxic or pathogenic properties. And these really do strip the epithelium down and really inflame and cause a lot of pain. We do have a rapid antigen test where we do a little throat swab. It has little antibodies in it, kind of like a pregnancy test, I guess, and you can get your results right away. Back in the olden days, we did do blood agar testing. We would just take a throat swab, put it on blood agar, and look for the hemolysis patterns. And if it was beta hemolytic, which is the property of strep pyogenes, then you were confirmed to have strep throat, and we'd give you antibiotics. Now, antibiotics are helpful not just to make the sore throat go away, but to sort of reduce the likelihood of strep becoming a systemic infection and getting into other body systems, which can actually be the much bigger and more harmful consequence, like it can get into your heart and things like that. That's no good. But I do want to clarify, a lot of people will have strep throat go away without antibiotics. It's just that they can become a carrier for strep, and then they're much more prone to strep in the future. They can transmit strep through kissing or saliva exchange, and that's no good. And like I said, it's those systemic, like blood infection type, like later down the road infections where it has become systemic that is definitely the most serious. So in this particular case, you can see that the throat is very, 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 very red and angry. This should hurt quite a bit. Oftentimes we'll see pus start to accumulate around the back of the uvula and the tonsils, and it's a very, very, very painful sore throat. But pus is very indicative of this strep. I will also say that a lot of times dental hygienists or people who have just a little bit more experience with looking inside the oral cavity can spot these kind of typical little round lesions in the back of the throat earlier, which can be diagnostic. There's like a few things that can be diagnosed from looking in someone's mouth. I think a lot of people, when they go to the doctor and the doctor looks at their tongue and they're like, say, they're like, well, you're just looking at my tongue. No, we're actually looking at all the different parts of like the oral cavity, just the epithelium, the tongue, like the surface of the tongue, the teeth, all of it. One complication that can result from untreated strep throat. So this would be someone who wanted to like do the old-fashioned, just get through it on your own, drink your tea, and don't take antibiotics, is scarlet fever. Scarlet fever is where the strep has become systemic, so it's circulating in the blood, and what we'll see is a like full-body rash. And this is a reddish macular rash, and we'll do something called like the glass test on this. You take a clear drinking glass and you push like the side of the glass onto your skin, and it will blanch if it's scarlet fever. And what I mean by blanch is the reddishness goes away when you press on it, and you can kind of see through the glass and see that happen. And then when you take the glass away, it gets red again. That's what we would call a blanch upon touch. If it does that, it's more likely to be scarlet fever than other things. There are some other diseases that can cause macular rashes, but it's an easy thing to check. It does sometimes also strip the surface, that sort of slippery coating of the tongue. That's going to be, a toxin is going to wipe that out. And also the very surface epithelial cells. It reveals, when you've stripped that top layer of skin basically off the tongue, the underlying like topography, like the little touch and taste sensitive structures of the tongue. It's very rough and irregular, and it kind of has the texture of the outside of a strawberry. It's called a strawberry tongue, and this really hurts, you guys. Like a strawberry tongue, if someone has that, they don't want to swallow. Like they don't want to breathe, they don't want to swallow. It's just misery. There are some other things that can cause that strawberry tongue, so you kind of have to rule those other things out too. But super significant signs, that blanching macular body rash and a strawberry tongue, and of course the wicked sore throat. Oh, I was going to say one more thing about strep throat before I move on to diphtheria. One of the things that can help with strep throat is gargling warm salt water. So strep is sensitive to salt, unlike other bacteria, like from your skin and stuff. So gargling warm salt water can actually reduce the bacterial load, and for whatever reason, it is an analgesic too. So it can relieve the pain as well as help kind of manage the symptoms of the sore throat from strep. It's a great home remedy. I highly recommend it. It's non-toxic. It's really, it's actually not bad for you either. It's not like, antibiotics forever and then resistance and all that kind of an issue. Okay, moving on to diphtheria. I gotta tell you, I'm sad that this is still in the curriculum because diphtheria, it just sounds like an old disease to me, like something from I don't know, my grandma's parents or some other older generation, but diphtheria is still going around. Diphtheria is Corynebacterium diphtheriae, and this is a pleomorph, and I'll just remind you what that means. It is a bacteria that at different stages of its life has different shapes. So the morphology in this case is not helpful. It's not really one particular thing. It can be a coccus, it can be a rod, it's all over the place. The serious problem with a diphtheria infection is that when it is pretty well developed, it can cause a membrane to form across your airway that is very, very tough, and you can't just cough that out. It can, in some cases, close the airway entirely and cause suffocation. So this is the most important in young babies who can't really communicate about what's happening in the back of their throat. You know, if you're an adult and something is starting to close across the back of your throat, you're going to know, you're going to communicate that, you're going to be like, oh, geez, I got to get to, urgent care or whatever. And we would figure that out. But babies can be really troublesome, and they don't have a full immune system. They are just a lot more vulnerable. So the fatalities with diphtheria tend to be in very, very young, less than a year old children. We do have a vaccine for it. It's the DTaP or the Tdap. The difference between the DTaP and the Tdap, the D stands for diphtheria, the T stands for tetanus, and the AP, I should say, sorry. The AP stand for acellular pertussis. So this is a triple vaccine. It's for diphtheria, tetanus, and pertussis, which is whooping cough. We give the highest amount of diphtheria in the combination in the children's form of this vaccine. And as you get like boosters later in life, we switch it to the tetanus one in front because you have residual immunity for diphtheria. But you need a tetanus booster like every 10 years. So we just kind of switch the concentration of the three, but let's just focus on the diphtheria for now. The other thing I wanted to mention is that we do want to sort of surgically remove that membrane from the back of the throat. You don't have to go into surgery under anesthesia, but someone's going to have to reach back in there and kind of cut that out because it's a very thick and leathery, tough membrane that you can't just grab with a pair of forceps or something. Here is a close-up of the pseudomembrane in the back of the throat. Like I said, adults are going to definitely know something's wrong and go take care of it. Pneumococcal pneumonia. So anything that is pneumonia, pneumo meaning lungs, and this would be sort of an infection of the lungs. I just want to sort of clarify that anything that gets into the lungs that is pathogenic can cause pneumonia. So it could be a bacteria, it could be a virus, it could be a fungus, it could be an amoeba, it could be anything. Like there's many things that can cause infection down there. Did I say fungus? There are fungal pneumonias too, which are really crazy. California has a lot of valley fever, which is like a weird fungal lung infection. Anyway, when we talk about pneumococcal pneumonia, it's going to usually be caused by Streptococcus pneumoniae. This is pretty common, gram-positive, alpha hemolytic, so it has partial digestion of blood capabilities, which is, a sign that it's dangerous, but not as horribly dangerous as beta hemolytic stuff like strep pyogenes. It has a capsule. Remember that capsule is a protective outer layer that's going to make it hard for your immune cells to clear it. It can damage host cells, and when they damage the host cells, damage to your host cells, like your body cells, can result in inflammation, and in a large amount of damage, it can cause necrosis. And I'll say this about pneumonia. Your body can handle a little bit of cell damage. It can't handle a lot. It reaches like this critical mass of how many cells have been destroyed, and then it kind of like, it just can't heal itself after that. It just forms scar tissue. So one of the hallmarks of pneumonia, from all types, but this is pneumococcal pneumonia, is patchy infiltrate on an x-ray of the chest. So what that means is when you can see here that the lungs should normally be full of air, they shouldn't have any density, the x-ray just passes right through them, therefore it's black and dark. These whiter areas are the evidence that there is something solid, either fluid or like clusters of cells that are inflamed or even dead. They're hard and dense, and that is reflecting on this x-ray, which means there's definitely something going on there. Other cases of pneumonia can vary. Some are opportunistic, but it just sort of depends. And like I said, anything that gets into your lungs can be problematic. That's why we want to stop it at the throat. Ideally, that's where I would stop, or even the larynx. Maybe bronchitis, that would be great to have like that be the last place. But pneumonia can be very, very, very serious, like I said, because the first way that your body is going to try to deal with that threat in the lungs is vasodilation, and fluid is sent to kind of capture that area, and that fluid fills up in the lungs, and then you can't breathe, and you get a really wet and productive rattly cough when you breathe, and yeah, bad times. All right, TB. So, oftentimes when I teach micro, people ask me this question, oh, Valerie, all these germs are so scary. What's the worst one? What's the scariest germ? What's the biggest, thing you're scared of? Is it COVID? Is it flu? And I always say, oh yeah, TB, for sure. TB has been a problem for a really, really, really long time. If you're interested, TB can infect birds and other mammals, but there's human forms of TB that I'm talking about. It tends to be transmissible. It can kind of depend on how contagious it is. Sometimes it takes prolonged contact with a person, like living with a person, to come down with TB. Other times, you might not even know where you caught it because we're around people all the time. So the reason I'm scared about TB is that it's just really difficult to treat. Now, healthy people can have what we call a latent infection, which means they might not even know that they have it, but they can be spreading it during that time, and maybe something happens in their life, like maybe they get cancer or something, and then suddenly the TB kind of rears its head. Also, I will mention a lot of our biological drugs that we give people for a variety of autoimmune diseases, everything, from MS to psoriasis, will interfere with the immune system mechanism that would normally keep something like TB from becoming a really big problem in your body. So you kind of have to get these routine TB tests just to make sure that you don't have TB. But the WHO estimates that there are about 1 billion cases of TB right now on planet Earth. Certainly it's not as common in the United States, but it is very common in certain parts of the world. And, as we get on airplanes and go from here and there all over the place in any amount of time, that is a recipe for a spread. So anyway, what do I want to say? This is an acid-fast rod. This is in the Mycobacterium family, so this will be an acid-fast stain that we would do. In this one, the counter stain has been methylene blue. So it's the pink cells that retain the carbofusion that indicate that these are TB. Now, one of the hallmarks of Mycobacterium is they have a very waxy, lipid-rich outer coating, which makes it almost impossible for drugs to penetrate, as well as our immune cells. So keep that in mind. It is certainly a difficult microbe to treat. It might take 9 months. It might take 2 years of antibiotic therapy. And I mean 2 years of hard stuff, maybe even IV antibiotics where you go and get an infusion at like a clinic or something, and that is super no fun. Here's how the disease progression works. You're going to inhale those droplets and you're going to get an immune response. Your body's going to take out most of them, but sometimes a few of those little microbes will survive and they form a little tubercle, which means they kind of create like a little hollow cavity for themselves. And while they're inside there, they're just replicating like crazy. And once they kind of reach a critical mass, they will break out and infect neighboring areas of the lungs. And the word tubercle is actually referring to these little kind of hollow, like hollow cavities, basically, that have stuff on the inside. Those little tubercles look like little dots on the x-ray, and that's kind of where the name TB came from. So I've kind of written out the steps of the pathogenesis. You inhale, there's going to be an immune response, but every once in a while there's going to be some survivors which are going to basically calcify themselves inside that little tubercle like pod, and then do their little thing, and then they're going to burst and start to move to the surrounding area. Now, like I mentioned, there are multiple antibiotics that we can use. We never want to use a single antibiotic for TB because of resistance. We always attack it from multiple antibiotic angles just to try to get synergism, find the weakness. And like I said, this is a really tough one to treat because of the waxiness, because it's actually very difficult to get drugs into the interior air parts of your lungs too. Like, just think about that for a second. It's got to be digested, or maybe we add it IV and it's going through the blood, but it's got to get to the lungs, and then it's got to diffuse out through the respiratory membrane into the air cavity of the lungs, which is not normally where medication would go, and then treat it there. There are some countries that routinely vaccinate for TB, and I think Eastern Europe is probably, it's very common there. And you should know that there are places that do routinely vaccinate for TB, because sometimes people will have had a vaccine and then they're here getting like a TB test for working in healthcare or something. And if you have a positive TB skin test, all that skin test is telling you is that you have antibodies, like you've had some sort of immune reaction to TB. Now, that could be from a vaccine doing what it's supposed to do, which is build your own antibodies, or it could be a latent infection too. But TB skin tests are not super perfect in that way. And I think a lot of healthcare workers, because you have to get TB tested to work in a hospital for clinicals, all of that, it's really good to be aware that any kind of vaccine history could make that test a false positive. We also have blood assays, and there are some newer molecular tests that are a little bit more expensive. I think the skin test is still pretty common, but I do think the blood test is going to completely do away with that in the near future. I'll show you a picture of that in a second. I will say that any kind of indication of further testing will lead to a chest x-ray or even a CT scan if we find something on the x-ray, just so that we can properly diagnose that and learn the extent of any possible infection. You know, you might actually do sputum testing, acid-fast test, and try to culture the bacteria, but it is actually often done in the capacity of screening for TB in hospitals or clinics. Here's the TB skin test. We basically inject intradermally, like a sort of a horizontal injection, so it's not deep into the, hypodermis. It's actually pretty superficially injected under the skin. And what we're looking for is a reaction where your body has existing antibodies that see that injection of a little bit of, TB looking stuff. And then that reaction is measured by a healthcare worker like 2 or 3 days later to determine if that is a positive test. I will say, these are not 100% accurate, right? There's going to be some issues here. You are going to have a reaction to this. I don't care what your immune status is or how many antibodies you have. It's a weird test, and it's going to cause a little bit of a bump. And people are like, oh no, is this positive? When you see a positive reaction, it's a big, angry, red, large reaction. If you just have a little raised bump and it's a little irritated, that's just normal. Here's what a bilateral TB chest x-ray would look like. You can see that this is very white here. It's pretty patchy, so it's well distributed. It's a little worse on the left lung than the right lung here. But this would be the worst case scenario, right? You've got basically this TB actively all over the lungs. Oh, and just a touch of scoliosis, wouldn't you say? Anyway, that's my last piece of commentary about that. All right, let's talk about whooping cough. So whooping cough, or pertussis, is caused by the bacteria Bordetella pertussis. It's gram-negative Coccobacillus with a capsule, produces a very, very irritating cytotoxin that really overstimulates the cilia on that respiratory epithelium and causes a really bad cough. We do have a vaccine for it. Like I mentioned, the D is for the diphtheria. The AP stands for acellular pertussis. So that's part of that trivalent vaccine that's sort of, you start getting it as a baby and then you get booster shots. And we've actually recommended one additional DTaP booster for people because the pertussis in particular, the sort of memory immunity from the vaccines, like if you finished your vaccines when you were 12 or something, it might not be strong enough by the time you're much older to have a really good response. So we are recommending an additional booster, especially if people are in healthcare settings where they're going to be confronting people with, different infectious diseases, or maybe they have underlying conditions like asthma, and that can kind of make them a little bit more likely to get like infections in their respiratory system, but no fun whatsoever. Now, most of the cases of whooping cough or pertussis are in children, and it's because they're not fully vaccinated until they're 12. And like I said, it can be highly contagious. Usually death is going to occur in infants, just because they don't have a strong immune system to begin with. But I will say that adults can get pertussis too. I have known some nurses actually who caught pertussis from patients and didn't recognize it in themselves, even though they had all the signs, because they're like, "Whoa, I don't understand, I'm vaccinated." Well, just remember that vaccine is kind of losing its efficacy because there are fewer and fewer people getting vaccines. So the pertussis is getting a little bit more common, and, everybody is vulnerable, I would say. There are 3 stages. There's the catarrhal stage, which kind of doesn't seem very special. It's just like a cold. You might have a sore throat, a little cough, nothing too scary. But if that cough progresses to stage 2, the problem is in stage 2, that's where the worst symptoms are. And it is so raging as an infection throughout your body that you don't really get a benefit from antibiotics because there's already so many bacteria. So that's a problem. And also I will say that this is gram-negative. So if you kill the bacteria, you release the toxins, the endotoxins, and that secondary toxemia can cause more damage to the lungs too. So this is basically the point where something is wrong and it's too late, right? And stage 3 is convalescence. If you do recover, let's say, you're fully immunocompetent and you recover, it's going to be a slow recovery. It's gradual. You're going to have a cough that's going to get, better, but it's going to take maybe weeks, if not months, for that cough to completely go away. And before we move on, I want to point out that the whooping cough itself is different than a normal cough. Like, you can have like a little cough with many respiratory infections, colds, flu, whatever. And it's like, you get a little chest irritation and you just feel like you kind of have to like spit it out basically, which is what a cough is. With the whooping cough, what I'll say is that cytotoxic toxin that irritates the cilia, it's constantly being stimulated, and it triggers a cough reflex because the toxin is on it, not because there's an irritation, which is why this is different. So a cough does not give you any relief. You know what I'm saying? Like, usually when you cough something up and you're like, oh, I had a little phlegm or something, oh, that feels better, right? That's not true with whooping cough. And what you'll see is people cough so violently that they kind of wheeze or whoop in between the coughs. So I'm going to demonstrate for you. This is my, I got to get in character. Okay, ready? Like, there's a wheeze between those coughing episodes, and I've heard it one time, y'all. Like, one time, and I like stopped in my tracks. And I was like, oh my gosh, that's whooping cough. Get home, get out of here. Like, it was a student in my class. And it was almost like there was a whistle in her throat. It was so like whistly. It was so weird, but it was like that like that sound is like unlike any other kind of cough. And when you hear it, there's nothing else that it is. It's pertussis. It's super serious. And I'll say one final thing. The worst coughing happens in babies, newborns. And sometimes they'll cough so hard that they have a seizure and lose consciousness and they can get brain damage. And this is the sad thing about whooping cough. It's like you don't realize they're so sick with the stage 1. But it's the stage 2 where you're like, oh my gosh, this is really bad. I need help, right? And then it's too late. There's nothing we can do. I mean, we can put them on like respiratory support, oxygen, all that, nebulizers, whatever. But like that's not the same thing as having antibiotics to kind of cure the infection. Oh, that was so exciting with all that coughing. Now we have to move on into our next particular microbe, which is a virus, the chickenpox virus, or more technically known as the varicella zoster virus, VZV. Most people just call it the chickenpox virus. We did introduce a vaccine for this, probably 35 years ago. However, what I'll say about chickenpox is there's still a lot of people who think people should just take their lumps and get the chickenpox the old-fashioned way. Like maybe some kid has it down the street and you're like, oh, hey, why don't you just go play with that sick child and get the chickenpox and get it over with and build your real immunity? There's definitely that school of thought too. And, you know, the interesting thing about this particular virus is it tends to be fairly benign in children. It causes a skin rash, itchy skin, vesicular rash. The reason why I'm putting it in the respiratory system and not the skin is that it's not as serious as a skin infection. It is serious when it gets inside your respiratory tract and it can get into your lungs. And when you have those vesicular lesions inside your lungs, it is a dangerous virus. You can actually die from that. So that's why you might be curious why I stuck it in here and not in the last lesson. But that's my reason why. I should also just dispel the myth that this has anything to do with chickens. There are a lot of pox viruses, and for whatever reason, they decided to name pox viruses after a lot of times animals. There's monkey pox, there's chicken pox, there's cow pox, there's all these poxes, and you're like, did we get this from chickens? The answer is no. This is a human virus. It has only primate reservoirs. Highly infectious, and it tends to be infectious when people are indoors playing, in contained spaces, and those aerosolized droplets have nowhere to go. So it's easy to catch this if you're around someone with chickenpox. And I remember the day I got infected with chickenpox. I was at my riding lesson when I was a kid. My sister was really into horses, and my mom always made me do whatever my sister was doing, so we always had to do things together. And so I rode ponies, which was a terrifying experience because ponies are just, I find ponies to be very angry little creatures. But one of the kids at the riding lesson was like, hey, do you want to see my rash? And I'm like, yeah. And so he showed me his chickenpox on his belly, and I'm like, whoa. And then it was the middle of August. I got the chickenpox. It was so hot. And my mom was like, you need to take all these baths with all this anti-itch stuff or you're going to get scars. And I was so unhappy. Anyway, that's my sad story. Initially, chickenpox is usually going to present on the torso, but then spread to the neck, arms, back area. It just kind of sort of spreads out from the center of you. We could treat this with antivirals, but to be quite honest, we usually do not. It's not usually that big of a deal. But sure, go for it if you've got a bad case. Pathogenesis, this is a double-stranded lysogenic DNA virus. It's going to insert itself into your genome, which means you get to keep this virus forever. And once you've had the chickenpox, when it asserts itself later, it is known as shingles. So chickenpox, shingles, same virus. One kind of is more on the surface of your skin, benign vesicular rash, like what you have in childhood. Shingles tends to be a lot more painful because this virus, it integrates into the genome DNA of your little nerve endings. So particularly the dorsal root ganglion, if that is something that you're familiar with, that's where your sensory nerves have their cell bodies. So your sensory nerves are being infected with this virus, and that's when it reemerges to irritate those sensory nerves. So I actually have had shingles before too. Interestingly enough, I had a outbreak of shingles right in the same place where one of my breast cancer tumors was. And when I told that to the doctor, they didn't really believe me. I was totally gaslit by that. I was like, wait, don't you want to know that my body was basically experiencing like stress at this exact location? I actually had a shingle scar before I had my mastectomy. But it was like, for some reason, they didn't see this association as being significant, and I totally did. I was like, I feel like this was my body telling me something. There was a lot of stress happening. There was something unhealthy happening here. It hurt. It was like a blistery rash, and I would basically say it feels like a second-degree burn. Like, it doesn't feel like chickenpox, which was kind of itchy. It just burned, and it didn't ever stop, is how I would describe it. Some people will refer to shingles as being like electrical burny pain, like if you're touching a hot wire fence and it kind of pulses. Anyway, that was my experience. Sometimes this virus can infect like facial nerves or optic nerves and cause facial signs and symptoms like facial paralysis or blindness even. Totally not good. Can alter the facial nerve, which would affect 2/3 of the tongue and ear. No fun. And again, shingles, because it's bad, we typically do treat that one with the acyclovir to try to, lessen the symptoms. And there's like a vaccine for it now. There's a new vaccine for it. It's a double vaccine. You get it over 6 months. I actually had that vaccine. And I gotta tell you, that was a hard one. Some vaccines, you don't really feel anything. That one, I had really, really sore arm and a fever and definitely provoked a good immune response. Here's chickenpox, okay? Notice that these are isolated, vesicular, little rashy bumps all over the skin, miserable sort of skin itches here, irritated. Try not to itch. You don't want to, leave a scar. Here's a miserable person with chickenpox. This one is actually kind of moved up into her facial area, but it probably would have started maybe around her neck or chest area. This is shingles. So notice that the rash is a little bit more contained, like it tends to be in little clusters. Definitely starts around torso, neck, back kind of area in clusters, and it looks like an angrier rash to me. Definitely painful and hurdy-burdy is how I would say. Here's kind of the end of the rash after maybe 3 weeks, a month. It can take a while for this to go away if it, is pretty large. Oh, I was going to say this other really interesting thing. I was in the micro lab once, and I had this student who was just barely pregnant. Like, she just finally got pregnant. She's super excited. And pregnancy can actually trigger shingles. And it did in her case, and this was her first baby. So she was really worried about the shingles. She went to urgent care, and urgent care was like, oh, this is just shingles. Your body's just kind of going through some stressors as it's, gearing up for your pregnancy. Here is your acyclovir. And she's a pretty small person, and they gave her like a pretty good dose of acyclovir to kind of wipe it out. And she just didn't feel comfortable with it. She's like, gosh, I don't want to do anything to hurt my baby. It's like, I'm still in the first trimester. What do I do? So she called her grandma back in Russia, actually, and her Russian granny was like, no, don't take this medicine. Take Simple Green. And I was like, what? Simple Green? You mean like the same stuff we use for the acid fast stain? Because we stained with Simple Green in the lab. And she's like, yeah, same thing. So they kept it in like their first aid kit, like in the Russian world in Eastern Europe. And I was like, whoa, that's so cool. And so I'm like, are you going to do it? She's like, yeah, just put it on the skin. And like it dyed her, she had it kind of on her collarbone area. So she put it on her collarbone and it was like very green. Like she definitely looked a little smurfy. But totally went away. And I was like, wow, I've never seen shingles like go away that fast. It went away in like 4 or 5 days. So perhaps there are other ways that we could also treat shingles. Doesn't have to be acyclovir. For diagnosis, usually we just like, hey, has it been going around your school? Has it been going around your friend groups? Usually that's the case. Usually people know the skin rash kind of looks very chickenpoxy or shingly, and we diagnose it. And like I said, we could culture it, but usually we don't. But, that is an option if we need to do genomic analysis or some other reason to do it. Complications, like I mentioned, are when they go into the respiratory system and cause inflammation and pneumonia. That can actually kill you. No joke, that is rare, but it can occur. The virus can also get into your brain and cause encephalitis, which would be the virus inside your brain causing, all sorts of cytotoxic effects there. There are immunocompromised people who've had organ transplants, people who have, different types of chronic diseases where it can be fatal. And, while there's not a lot of death from this, it's not zero for sure. And like I said, most of these are going to be adults who have medical problems. All right, let's talk about mono. Mono is caused by the Epstein-Barr virus. This is in oral secretions of asymptomatic adults, and we're a very kissy species. It's very easy to spread this virus. In fact, we think absolutely most people on this planet have been exposed to Epstein-Barr. Like 95% of them carry this virus in their nasopharynx, oropharynx, and yet Epstein-Barr is not that common. This is not what I would consider a germ theory of disease. This is much more of a you become susceptible theory of disease because something else is going on. So the types of people that we see with presentation of Epstein-Barr are people who are chronically stressed. That means college students are probably number one, and also folks in the military who've been deployed into combat, which is a very, very stressful situation. Your body basically just gets run down, and then this virus that you probably just have hanging out, doing nothing most of the time, can start to assert itself. The triad of symptoms, and you must have all three. You can't just have one of these. You have to have all. Fever, really bad sore throat, and lymphadenopathy, which I'll show you a picture of next, but it's very swollen lymph nodes in the neck. You have to have all three of those. And here's the problem with Epstein-Barr. You can do antibody tests, but you can sometimes get a false negative if you take this test too soon. And it just happens that it takes time for your body to produce those antibodies. So if you're like, oh yeah, I'm sick, and you go to the doctor and they do the test and like, yeah, it just seems like a cold. I'm not testing you positive for mono or whatever. Just go home and rest in fluids, and you might miss it. But certainly we do want you to deal with the lifestyle factors that kind of led you to get this in the first place, which is like the stress. So you kind of have to rest, recover, push lots of fluids. It can be hard when you have a sore throat. You should actually avoid antibiotics. Remember, this is a virus, y'all. We don't prescribe antibiotics for any kind of virus, but you definitely don't want to do it for this one. It can actually cause complications. This is what the lymphadenopathy looks like. It's a pretty nasty, swollen neck lymph node. It could also be under the jaw. If you're curious, this is in the herpes class of virus. That's probably why it's so contagious and everywhere. And like I said, we kiss, that's it. Everybody's going to have this pretty much by the time they reach adulthood. It infects B cells, and this is an important point. B cells are in your body the cells that produce antibodies, okay? So it's the antibodies that are eventually going to neutralize this virus. So remember what I said about the early detection? It's going to take you a while to make these antibodies because the antibody producing cells are being attacked here. So that's tough. But you do have a vigorous inflammatory response. In fact, the healthier you are, the harder you're going to fight this, and sometimes the sicker you become. It is a paradox. In this case, it is your immune reaction, how strong that reaction is, that determines how sick you get. Isn't that interesting? So, yeah, that totally sucks. And like I said, we might see really misleading tests early on. Now, complications from mono are not minor. When I'm talking about an organ rupturing, the spleen rupturing would basically cause sepsis in your entire abdominal cavity. That could kill you. neurological involvement, airway obstruction, whoa, hepatitis, hemolytic anemia, blood clots, and other problems. I mean, wow, like these are like serious, and that's the acute complications that can occur if your body is fighting this as hard as it can. The chronic complications, and I think this is actually interesting, are blood cell cancers. So think about this virus attacking your blood cells, right? A B cell is one of the white blood cells. So if your white blood cells have been kind of taken over by this virus and there's, viral stuff like basically reprogramming those cells, that's a recipe for lymphoma. So it's serious here. Lymphoma is no fun. You might need chemotherapy or like a bone marrow transplant if you have lymphoma. That could be a life-altering complication. Like I said, early antibody tests, meh. Therapy, supportive care. We live in a culture where we need to be able to take a sick day or 2 or 3 or 4, right? You should stay home when you're sick and get better. That's the best medicine. And then, push fluids. If you've got a fever, 100 mils of fluid every hour for every degree of temperature. It's 100 mils every hour for every degree of fever. If you have a 3-degree fever, that's 300 mils of fluid just to replace what you're losing in dehydration. And unfortunately, I think those are the best. If you really need prednisone to reduce your inflammatory response, if you're just like having one of those really crazy acute reactions because your super strong, healthy immune system is just going crazy, we could damp that down. We have tried other things, but those tend to be the most standard. I will say there's also something that's very interesting with mono if it is not treated in certain people, that this virus can kind of slide into a chronic state of what we would call chronic fatigue syndrome. This is similar to long COVID. It is similar to some of these other like fibromyalgia kind of issues where this virus basically just keeps your body in this state of fighting and it's exhausted from it. And there is no therapeutic agent that can stop that from happening. We can't just be like, oh, well, here's some, antiviral therapy, some acyclovir or something. That doesn't work. There is some potential that vaccines can kind of help reset those people who've slid into this long chronic fatigue issue. But it doesn't work 100% of the time. It can work, but it's, I think, in the very experimental stages. But there is maybe some hope. Hanta is next. Hanta is a virus that is spread through the secretions of rodents, particularly mice, wild mice, and sort of the domestic horrible mice that you might get in your garage at some point. The saliva and urine kind of gets kicked up into the air and you can inhale it and you get basically a respiratory infection that starts pretty mild but can get really serious really fast. The problem with Hanta is that there is no treatment, there is no vaccine, there is no cure. All we can do is really offer supportive care, which would be oxygen and maybe fluids and rest. So that's pretty serious. In terms of the clinical diagnosis, it's the Hanta pulmonary syndrome. And like I said, it's usually going to cause a fever at first. And I should also speculate here that a patient would have some sort of history where mice might be present, right? Maybe cleaning something out or, the basement. Oh, yeah, I had to deal with some dead mice or something. There's a lot of rodents in our world, right? They live here too. So of course they're going to try to move in with us because this is probably the best kind of living situation they could ever imagine. They're just living, right? And if they are carrying this virus, you should have some sort of, history of cleaning up rodent poop or something like that to kind of connect the dots to this illness. This virus does cause capillary leakage, which is the same thing as any form of pneumonia. Your lungs are going to fill up with fluid. But that makes gas exchange very difficult, which is hypoxia, lack of oxygen. The CDC, I think the CDC is still looking at this. They've really, really cut back on all the stuff they're doing. It's so frustrating. But Oregon is an active hotspot for the surveillance of hantavirus. So California, Oregon, Washington, we think that this virus kind of started from the southwest, but it's kind of moving up north. And it's particularly interesting to track that and know what's happening here because we think, the waves are still coming. Prevention, wear a mask. And maybe, deal with the rodent infestations, like call a specialist, I guess. Here is a very, very problematic lung x-ray. You can see how much patchy infiltrate there is in these lungs. This is extremely serious. Like this person would have a really hard time breathing through all of that fluid. Now, here's the most updated map I can show you. And I do kind of want to just remind you statistically that Oregon has not had a lot of these cases, but Oregon is only about 1/100th of the U.S. population, okay? So if we look at 300 million people who live in the United States, only about 3 million people live in Oregon, so it's about 1%. It's pretty easy to remember. We should really only have about 1% of the cases, okay? Let's compare this to California. California has a lot of people, has about 30 million people living in California. That's 10% of the U.S. population. Now, if there were 78 cases in California, and that's 10% of the population, then we should have 1% of the cases, right? But we actually have a third of the cases of California, which makes Oregon statistically very interesting here. I would say even more about Washington if we lived in Washington. Washington has a little bit more of a hot spot for Hanta, but we're very interested in the cases of Hanta here. So keep that in mind. I don't think we're finished with hantavirus in Oregon, even though these maps are sort of, this is a longer term view of the epidemiology here, but hopefully we'll see some more updates soon. What do I want to say about SARS, MERS, and COVID? Well, let me say this. Coronaviruses are highly mutagenic, which means they like to mutate. They just relax their DNA repair mechanisms and just kind of, freely change themselves. The first epidemics originated in China. I think that is interesting. I think a lot of that has to do with the fact that China was not a very open country for a very long time. And then when they rapidly developed and kind of created their corridors for tourism, people were going in and out. And it was just there hadn't been a lot of germ exchange between the world and places in China ever. And so we're sort of getting these first points of contact. That is hard because if we've never had experience with certain viruses, we don't have inherent immunity, we don't have memory of it. It's hard on us when we have to do that all at once. So, COVID was a pretty epic outbreak. I think, if I could just philosophize about COVID for a second, we're very lucky that virus became more transmissible and less pathogenic. Some viruses do that. There are examples like Marburg virus, Ebola, things like that, where they went the other direction. And you can see they'll wipe out 100% of the people who catch it, but then they kind of die out because the hosts kind of figure it out real fast and sort of stay away from those people. With a more transmissible virus that's less pathogenic, people don't, drop dead. They just pass this virus around and around and around. And here we are in the washing machine of COVID. Just, it comes back every few months. Oh, yeah, I don't even know if I have a COVID test anymore. We're lucky that it went in that direction. It didn't always have that, feel to it. In the beginning of COVID, that was scary. With all the people on respirators and the morgue trucks and man, I can only imagine how terrifying it was to be on the front line, like in the ER and the ICU, like trying to keep people alive. And then it kind of went through these phases of people stopped believing it was real. And then they were like really, really nasty to like nurses and respiratory therapists. And it was so hard on those poor, like people trying to keep people alive and do the right thing. And it was just, wow. Sometimes I'm embarrassed how we treat people in this country. It just doesn't seem right. But we know that it's pretty contagious, spread through aerosolized droplets, fever, and then the symptoms kind of start. And, you know, with these coronaviruses, we usually see fever, sore throat, headache. Sometimes there's body aches, and sometimes a variant might have something special to it. Just sort of depends. Like, do you remember one of my favorites was at the very beginning of COVID when people were like, oh, there's something going on in people's toes, like their coronavirus toes. And like they were like pink or something like that. And I was like, oh, that's cool. Anyway, I think, you know, we've all been through it. I think some people were very traumatized to it. I think, you know, we learned a lot. We learned kind of what people would and would not do. From a purely epidemiological perspective, you know, our shutdown was not complete, and so we never really got the benefit of like that quarantine and a reset. I don't know. And now we live in this country that's like, no, masks are a violation of my freedom, and I would rather take medicine from the veterinarian, ivermectin or something, which is a deworming medicine. It actually works really great for deworming horses. I don't know what's happened. It's so weird where we are with conspiracy theories and like all this. I'm just like, I don't buy any of the conspiracy theories, and I just kind of look back on the last few years, and I'm kind of sad. I'm sad for us that, you know, it didn't bring us together. I guess kind of made us angry. But anyway. Enough about that. Single-stranded RNA coronavirus. It's unique, so you don't have immunity to it, which is why everybody got sick initially. Excuse me. Had to cough there after. Must have been my whooping cough like drama. Anyway, it is an enveloped virus, and it works great to hit it with bleach or some kind of disinfectant. It can't withstand that. It just dehydrates and goes away. Clinical manifestations are usually in adults. Highest morbidity and mortality. Again, it's the paradox of having a fully strong immune system. You like kick it with everything you've got, and sometimes it's your own immune system doing those symptoms to you. Incubation period can vary. Sometimes it's 2, maybe 7 days, sometimes a little longer. Fever, headache, malaise, which is you feel lazy, myalgia, which is muscle aches, mild respiratory symptoms. And we have all sorts of ways of testing for it. You can get just the rapid test or send it to PCR if you really want the genomic analysis, fever, and cough, difficulty breathing. I would say for the most part today, most people just do supportive care if they have COVID or any of those. There are some people who might be at risk and need like further treatment that might be antibodies or something like that. But as these strains kind of mature, some of our older antibodies are kind of outdated because the virus has mutated so much. And to be really quite honest, I don't know if the government is going to be sponsoring research into future treatments for this particular respiratory infection. I think they've just sort of written it off. So I guess we'll see. It could come back and be more deadly again. That is not unheard of. But maybe do a better job isolating. I think masks are great. I always wear a mask when I go into the hospital. I mean, I have to go to cancer doctors all the time. So out of respect for the people getting chemotherapy, I always wear a fit-tested KN94 mask. I have them flown in from a lab because they've been tested, and I love my masks. They're super cute, I think. Travel advisories, if you know you're going into a hotspot, just pay attention. And, you know, there is a vaccine, but like I said, I'm not really sure how much energy the government is going to put into updating these vaccines, because now it's pretty political. All right, let's talk about the other big bad. So you remember when I said there's a couple big bads out there, Tuberculosis being number one because it's so ubiquitous. It's just everywhere. The second big bad is always the influenza virus because it does have the potential to be very, very, very pathogenic. Spread in the same way as respiratory infections. You're just around someone coughing, sneezing, breathing from their sick self. The difference with the flu symptoms is that the onset of symptoms is very sudden and very severe. So most illnesses, you kind of have a run-up in the prodromal period where you don't really have symptoms, or the symptoms are nonspecific. Like you just might be tired one day. You might be just like, oh, I think I'll skip working out. That's different here. This is like you're fine in the morning, and by afternoon you feel like you've been hit by a truck with high fever, headache, muscle aches, runny nose, sore throat. This can cause pneumonia, which is usually what can kill you. It's the pneumonia. If we catch the influenza early within the first 48 hours, we do have antiviral treatments that can lessen the viral load and make your life so much easier. It's just really critical that we get that medication in you within the first 48 hours. After that, there's so much virus that those medications don't really have the same impact. So that kind of leads up to the vaccine, which is, well, if we don't have a really good way to stop you from getting super sick when you catch the flu, maybe we can keep you from getting it in the first place, which is the influenza vaccine. We do see epidemics of influenza every few years. There's also a 50-year pattern and a 100-year pattern of really bad influenza. So those years tend to be like generational flus. Like the really, really, really last bad flu outbreak we had was the 1918 Spanish flu. And then I would actually put the swine flu of like 2008 in there. That was a pretty bad flu too. That actually kind of caught us off guard. It was like, it came in the summer and not the fall. It was just kind of like an abnormal one. But those are basically the sneaky flus that basically we're not prepared for. We don't have any immunological history, or maybe it's been 100 or 50 years. So like younger people will catch the flu versus really, really old people. The key here is that the flu virus has two types of mutations: antigenic drift and antigenic shift. So antigenic drift is just sort of this slow, gentle, a little mutation here and there over time. And, you know, over many, many years, it can drift pretty far and it can actually look like a pretty different virus, and you might get sick from the same kind of type of virus again. Antigenic shift, however, is different. Antigenic shift is a wholesale reassortment of genetic information that happens in one season. And one of the weird things about flu is that when it's the end of human flu season, the flu virus usually enters animal hosts, and those are pigs or birds usually. So we use a lot of pigs in the United States for meat, and there's a lot of birds either for meat or for, you know, nature. Like they are migrating birds, like flying all over the place. So maybe the migratory birds like help spread it, right? But like in the animal form, since the host is quite different, the virus just has this big antigenic shift. It just like shuffles all of its genes. And then when it comes back the next year, it's like a whole new virus. That is why we need a new flu vaccine every single year. It really has to be updated and changed because it's a different virus. Like it's been completely shuffled. So yeah, you do have to get a new virus every year. Pathogenesis about the flu, in extreme cases, the danger here is that it kills cells. It doesn't just irritate them. So you can deal with a little bit of irritation, like I said, but you can't deal with wholesale destruction of your lung tissue. And like I said, it's the rapid and sudden onset that, and the severity of the symptoms too, that make this completely unique. Recovery can take a while, and sometimes, you know, you might be a little tired and have a cough for, you know, a couple of months if you've had a bad flu. Diagnosis, known circulation. We do have surveillance of this still at the moment, thank goodness. So once we start to see flu circulating, we know exactly what the parameters of that version of the flu are, and then we can kind of tell all the doctors to be on the look for that. and we know exactly what that flu is, and then all the tests are updated and stuff. We do have, rapid flu tests, just like COVID tests. Sometimes the sensitivity can be low, at least at first, right? Because, if you're using an older test or one that hasn't been updated with the modifications that the virus has every year, you might not get 100% results. I would say 60% is kind of troublesome. That's missing a lot. But once we know, it gets going and all of those numbers get better. In terms of the flu vaccine, we do kind of look at where the flu is at other parts of the globe during their alternate seasons. So like in the Southern Hemisphere, Australia, different places in Europe, for example, that have warmer climates in our winter, their flu season is sort of opposite as ours. So we'll kind of be exchanging viruses back and forth. So a lot of times we'll see, oh, well, the flu circulating in the last cold season in parts of the world was this strain. Let's put that strain into our new flu vaccine, thinking that will basically move into the United States. Is that a perfect system? No, but it takes months to actually engineer the virus. So we don't want to wait, if that makes sense. We want to predict and do our best guess as to what the flu vaccine is going to be circulating. We do a pretty good job most of the time, but it's not 100%. It does require a prediction. Our current influenza vaccine this year, if you're getting the egg-based vaccine, these are the viruses that are part of that vaccine. The cell-based or recombinant vaccine that doesn't use eggs, very similar in terms of the lineages. You should know that the United States still kind of clings to the egg-based viral growth process. I wish we didn't, because I think chickens are very just physiologically so different that that can actually cause antigenic shift in the virus being grown. But I'm not in charge, so I guess here we are. I really, really feel like these vaccines could be improved because a lot of people do not take them, and therefore the flu just continues to swirl around from year to year. Groups recommended for vaccination for the flu. Y'all are probably number one because you're in the front lines. We always try to keep our healthcare workers safe first because they're going to be intercepting people coming in who are sick and experiencing something we don't even know what it is. Next in line would be our elders, who are just more vulnerable immunologically, especially if they're in a facility, because those facilities are sad and stressful, and they're hard on people. They're sick. They're confused. It's just awful, right? Then people who are prone to respiratory infections for whatever reason, young people, and also pregnant women. You should know the flu really likes to do a double whammy on pregnant women. And it's one of the scariest late-term pregnancy complications that a pregnant woman can have. The death rate in pregnant women from flu is much higher than normal, which we've seen that in other types of respiratory infections too. But it's really sad in the flu when the mom is kind of brain dead and they maybe try to keep her on life support to deliver the baby. That actually happens, which is just awful. What I want to say about H1N1, which is the swine flu, this was one of the bigger flus that we had in recent times, I think 2008, is it's still very common in Portland. I don't know why, but a lot of flu in this particular area tends to be H1N1. And here's the thing about H1N1. It's flu plus diarrhea. So that's how you know that it's the H1N1 and not another form of flu, is if you have GI symptoms, stomach ache, cramping, and, diarrhea, that's the swine flu. Common cold. I think this is so interesting. We've really tried to cure the cold, never done it, tried everything. And, a lot of people just think the cold is just one of those rites of passage. You just get little colds. Most of them are rhinoviruses. Those are the ones that cause runny noses. The others are coronaviruses, things like that include COVID. That's a coronavirus. That would also be something that could be like a cold virus. And in some ways, I think COVID might be evolving into something like a cold, because cold, of course, is not a type of virus. It's more of just a common name for, you must be a little bit sick. Don't know what it is, but you'll be fine, right? That's what we refer to as the cold. Interestingly, we have had vaccines for the cold. None of them have worked. This one just changes too much. And this is very, very interesting data. We do think that the cold and the flu compete. So this was interesting data from the first swine flu epidemic that we had in 2008, where cold season happened first. And once cold season started to die down, then the influenza season started to rage. And these are actually hospitalizations. And so we think that maybe we don't want to eliminate the cold. Maybe the cold is the easier way to kind of occupy whatever's infecting us so that when those are gone, now the nastier pathogens move in, like flu. And, flu is pretty devastating. Respiratory syncytial virus is one of the things that circulates first late summer, early fall. Tends to have a pretty bad cough, I would say. And also sneezing, which is not a typical symptom of a cold. Definitely bad in kids. We do have a vaccine now for RSV. It's a pretty new vaccine, which is pretty exciting. I haven't seen a lot of people, break down the doors to get it. But certainly it is an option for people who need a little bit of a boost.